because
We can
need
start.
to start. Okay, I will share the screen now. Can you all see the screen? Someone, just make sure that you can see.
Yeah, we can.
Screen, then you can see. Okay, I'm from my hometown, so I'm not sure about my connectivity. So if there is any lag or some issues, just let me know. Then today, I think we have to cover two topics. One is respiratory distress and neonatal resuscitation. First, we will start with the respiratory distress, then we will move on to the neonatal resuscitation. And both are easy topic. I will first tell about the respiratory distress. So this is one of the common topic that we used to be questions on MCQ and SBR. So we have to know in and out about these topics, because almost there will be two MCQs. MCQ mean in MCQ plus SBR. Almost two questions will be there, and no chance for us to be asked on the SEQ, because these are the small topics, so there will be less chance to be asked on the SEQ. Sometimes you may get the questions for the short essays, SEQ, the short essays. Otherwise, this is a common topic to be asked in the MCQ. So we have to know in and out on that. So then we will be moving into the topic. Okay. So respiratory distress, we have to know the causes. So we have to study under the causes. There are several causes. So these are the common causes that we will be asked questions. So like I have listed around 10 topics here. I have used the source as the new pediatric book. So if you want to refer for any further notes or information, you can refer that book. That is a good book to study this topic. No need to study anything other than what have been taught in that book. That is more than enough. And other than the causes, there will be cardiac causes also, which can cause respiratory distress. So, but anyway, we will be covering the cardiac causes in separate topic. So I haven't included that cardiac causes in under this topic. The cyanotic heart disease that also can cause respiratory distress. So these are the causes coming under respiratory system and the gastrointestinal system. So we will be looking at it one by one. So when we are talking about the respiratory distress, we have to know how usually the child mean the neonate present. So after the birth, probably soon after birth or sometime after the birth, usually the child or the neonate will be presenting with these symptoms like tachypnea. Usually the range of the respiratory rate of the neonate will be 40 to 60. So anything more than 60 in a neonate, we will be taking as a tachypnea. Tachypnea means higher respiratory rate. And also when there's respiratory distress, child will be having recession. Like there are several recession. Commonly we are looking at subcostal, intercostal recession and grunting. So there will be the grunting sound will be coming out of the mouth. So that we can say. And the nasal flaring. Nasal flaring, we know that there will be widening of the nasal canal. So that is nasal flaring. So these are the features that usually we see on a patient with the child with the respiratory distress. Other than that, the question they can have, they can give a lot of features. So we will be looking when we are doing the MCQ at the end. So we will be looking at one by one. The common cause for the respiratory distress is a congenital pneumonia. So if we look at there, I have listed several causes, almost 10 causes. But if you compare all the causes, congenital pneumonia is a common cause. So we have to know that. And usually for the neonate, to be causing a congenital pneumonia, the causes are group B streptococcus and the E. coli. So those are the common organisms that we have to know. Sometimes it may be asked in MCQ. And whenever there's a cases of the congenital pneumonia, we have to look for, this is for the clinical thing I'm telling, we have to look for the risk factors for the congenital pneumonia. For the development of the congenital pneumonia, the neonate usually have the risk factors, like maternal risk factor. So in the maternal risk factor, we have to look for any prolonged rupture of membrane. So there will be more than 16 hours of rupture of membrane. The features of chorea amnionitis during the delivery for the mother, like a fever, foul smelling of the liquor. So these kind of symptoms would have been given in the history. Like in MCQ also, they usually give those features as a evidence to identify the case as a congenital pneumonia. So we have to actively look for these features, the maternal risk factors for causing the congenital pneumonia. And if there's a congenital pneumonia, the problem is this is a common cause, and also there are several other causes also. It is so difficult to differentiate other causes from the congenital pneumonia. So whenever we tend to treat a patient with any cause of respiratory distress, usually we are giving the antibiotic cover, because thinking that we cannot exclude congenital pneumonia at once. So that is the most important thing we have to know. So the investigation that we have to do to identify congenital pneumonia, that's a clinical diagnosis. With the investigation, with the help of the chest X-ray, we can clearly diagnose congenital pneumonia. So the treatment, there are several treatments, like the baseline treatment is there, like resuscitation, fluid therapy, and the specific management for the congenital pneumonia is antibiotic. That we have to know. Other than that, there are several causes. The specific treatment will be antibiotic, that is IV penicillin to cover group B streptococcus and the gentamicin to cover E. coli. That we have to know. So these are the common organism, and these are the antibiotics. We are starting empirically, because with the studies that we have done up to now, we know these are the common organism. To cover the organism, we are doing that. Along with these antibiotics, also we usually do a blood culture, and if it's possible, if it needed, other culture. And on seeing the organism, then we will change to the proper antibiotics later. This is empirical antibiotic. We are starting at the initial of management. After that, if the organism is something else, we can change into other antibiotics. These are the empirical antibiotics we usually start at the beginning. Then the respiratory support, according to the need of the child, we will be looking at what kind of respiratory support we have to give. Sometimes we may giving this just oxygen supplementation with the nasal prong or face mask, up to sometimes we may need ventilatory support. That may vary according to the case. So that up to this level, we have to know regarding the congenital pneumonia. When we are giving a case regarding the congenital pneumonia, the main thing is we have to identify the case as a congenital pneumonia. If we do that properly, then the rest of the case is so easy. I think that's all for the congenital pneumonia. If someone have any questions or any doubts, just ask me. Okay. Then we will move to the next one. Then the transient tachypnea of the newborn. So the name itself explains what the condition. Transient means for a short period of time, there will be a respiratory rate for the neonate. So that is for the short period of time. After that, spontaneously it will resolve and the newborn will be normal. So after the birth, it will be there for only some time, some hours, like 4 to 6 hours. There will be the tachypnea. Then spontaneously it will be cured. The child will be okay. This is a normal condition. No need to worry that much. If the patient is having transient tachypnea of newborn, identifying this condition is very, very important, because it usually occurs in a child who is born on a term period via the cesarean section. The problem is usually when we are delivering a child through the vaginal delivery, at the time of the delivery, when it's coming through the pelvis, there will be a compression of the head. So that causes the hypoxia. Due to the drive of the hypoxia, there will be physiological changes in the newborn, and the fluid within the lungs will be reabsorbed into the circulation. But when we are delivering a child via the cesarean section, that hypoxic drive is not there at the time of delivery, because without any tension, we are just delivering the baby. Sometime while doing the cesarean section, there will be a remaining of the fluid within the lungs. Due to that, there will be a tachypnea. That will be there until the lung fluid is completely absorbed into the circulation. So there will be only for the transient time. So that we have to know. This is a condition usually we look at in a baby who born in a term period and the cesarean section time. Okay. Then if you want to diagnose it properly, usually we know that condition because the child will be a term baby and delivered via the cesarean section. If you want to diagnose it properly, then we can go for the X-ray and we can look for the fluid shadows. So that is, they are calling the wet lungs. We can see in the X-ray. So management, usually we don't need any management because we know that is a transient condition. But again, the problem is when the patient develops this distress, we cannot differentiate from the congenital pneumonia at the beginning, sometime. So sometime we may need to start the antibiotics. That's why I have mentioned IV antibiotics for this patient. The antibiotics is not for the condition of transient tachypnea of the newborn. It is for the congenital pneumonia because sometime in child we cannot differentiate both conditions. In a small child just delivered now, we cannot differentiate. So until we excluding the sepsis or pneumonia, we are giving the antibiotics. Once we sure that this condition is transient tachypnea, we can stop the IV antibiotics. So that's what we have to properly know that. Don't get confused on that. That's what I have mentioned, IV antibiotics until the sepsis is excluded. Sepsis means it can be congenital pneumonia, any other kind of condition. Sometimes if the condition is very severe, like that is so rare, we have to go for the respiratory support. That is very, very rare condition. If we need only respiratory support, otherwise it is a common condition that resolves spontaneously. No need of anything. If we know that this condition is a transient tachypnea, nothing else, we don't need to do anything, just observe the child, some amount of supplement oxygen, that's all. No need of doing anything else. Just we can manage the child as a normal child. So have you got clear on that? Because sometimes we may confuse with the respiratory support and the IV antibiotics. Yes, is wet lungs in X-ray means fluid in the lung. Yes. Is there any doubt or any question? Just ask me. I think we can move on. Because I think transient tachypnea has not been asked in the MCQ. Sometimes in the MCQ they may ask this condition and may be giving an answer as a IV antibiotics as a must, but that is wrong. So I have again explaining, I have given IV antibiotic because that is to exclude congenital pneumonia, not for this condition. Okay. If someone have any doubt, just ask me. Okay. Then the other condition is a meconium aspirations. We know this is a common condition. That is commonly common condition means that is commonly asked in the question. So we have to know meconium aspiration mean while when we are doing delivery, at the time of during the period of delivery, due to the hypoxia, when there is hypoxia, there will be a relaxation of muscle. So the meconium will be released from the anal canal into the amniotic fluid, and it will be absorbed into the baby's respiratory system. That is the meconium aspiration. The problem with the meconium is meconium it is like kind of chemical, so it can cause the pathology in different ways. So we have to have an idea about the meconium. So meconium, it's a thick one, so it can go into the respiratory tract and mechanically it can obstruct the tract. That is one kind of pathology it can cause, airway obstruction. Second one, it is kind of chemical thing, so it can cause and induce the inflammation. With the inflammation, it can cause the chemical pneumonitis, kind of inflammation in the alveoli. So chemical pneumonitis. And meconium, if the meconium go into the respiratory system, in other hand, it inactivate the surfactant. Surfactant is needed to keep the alveoli open. So meconium go and inactivate the surfactant, so there will be a lung collapse. And also it can cause persistent pulmonary hypertension in the newborn. So these are the kind of pathology cause to cause for this respiratory distress. Just have an idea. Usually it occurs soon after the birth. If there's a meconium aspiration, the child will present with respiratory distress soon after the birth. We have to know the proper management of the meconium aspiration. So we have to know that respiratory support. So if the patient is need resuscitation, we have to do the resuscitation, and the definitive management of the meconium aspiration is sometime due to the inactivation of the surfactant, we have to go for the administration of the surfactant. For that, if we want to administer surfactant, we have to intubate the baby, because without intubation we can't deliver the surfactant. So we have to intubate the child and give the surfactant. And I have already told you, congenital pneumonia confuses with every cases. So here, other confusion, we can't straight away exclude congenital pneumonia in a case of meconium aspiration. So anyway, we will be starting on the IV empirical antibiotics, penicillin and the gentamicin, until the congenital pneumonia is excluded. So we will be starting the IV antibiotics, and we will monitor the child. Once the child is normal, we will start this breastfeeding. This is the meconium aspiration. I have explained why we are giving the antibiotics and why we are giving the surfactant. These are the reason we are giving both these drugs. Okay. I think, oh, that's okay. If one more to ask me. Then the surfactant deficient lung disease. Surfactant deficient means there is a problem with the surfactant, the amount of the surfactant. So what happen is, usually the surfactant which is needed to keep the airway open is produced within our lungs, but we know that physiology that by the type 2 alveoli cells, after the 32 to 34 weeks of gestation only, the surfactant is produced. When the child is born before the 34 weeks of gestation, there will be a problem in the production of the surfactant. There will be a deficiency. So that is one cause. Other cause is the gestational diabetes mellitus or diabetes mellitus. So if the mother is diabetes, the child may be having the surfactant deficiency due to this condition. These are the two common reasons to see this condition. So we have to know the cause. And usually, if there's a surfactant deficiency, the child will be having the respiratory distress soon after the birth. That's what I have mentioned, within 6 hours. Soon after the birth, the child will be having the problem. Then, how to manage the child with the surfactant deficiency? The management is respiratory support we have to give. How we have to give the respiratory support is, initially we can go for the CPAP. And once we want to deliver the surfactant, we have to intubate the baby and ventilate, because we are delivering the surfactant, the synthetic surfactant via the endotracheal tube. We have to put the ET tube, and we have to deliver the surfactant through the ET tube. So we have to anyway intubate the ventilate when we are going to do the surfactant delivery. And again, we are giving the IV antibiotic for the same reason. We can't exclude sepsis or congenital pneumonia immediately. So until it is excluded, we have to give the surfactant. We have to give the IV antibiotics. That's why at the initial I have told, congenital pneumonia will be coming under each and every topic, because there is a confusion. We can't directly exclude the condition. So until that, we have to deliver the IV antibiotics. Okay. Then the next condition, tracheoesophageal fistula. This is also
okay. That surfactant deficient lung disease is called by respiratory distress syndrome. Okay.
Respiratory distress syndrome.
No, that is surfactant deficient lung disease.
No, the surfactant deficient lung disease has other name of hyaline membrane disease. I don't know about the respiratory distress syndrome.
Okay. Then no.
There's an other name for the surfactant deficit lung disease that is called the hyaline membrane disease. That is an old name. We are no more using that name. Now the name is surfactant deficient lung disease. I'm not sure whether it is also called the respiratory distress syndrome.
Okay. Up to now, you tell about 4 conditions. Within that, only this, apart from congenital pneumonia, all others are presented soon after birth, within 6 hours.
Yes, congenital pneumonia things. I will explain that.
Present anytime.
Yeah, usually each and the condition I have explained all present within 6 hours. The congenital pneumonia usually we think it present after 6 hours. After 6 hours.
Okay.
Because
if the MCQ said that after 3-day-old child presented with respiratory distress, it won't be that other 3 causes mostly.
The thing is, usually, if we take, we will take this meconium aspiration. Meconium aspiration usually soon after the birth, the child will present with the respiratory distress.
Okay.
And if you don't treat the child properly, then it can continue up to 3 days. I'm not sure whether the child
can survive after 3 days.
No, after 6 hours, the onset can't be. It usually onset within 6 hours. Usually soon after the birth.
Okay.
Means once the child is delivered, there will be a respiratory distress. That I want to see. There's a cutoff of 6 hours.
Okay.
I don't want to confuse that. That's what I didn't mention the congenital pneumonia. Usually, we are usually taught that congenital pneumonia occurs after 6 hours because there should be a period for the development of the sepsis to cause this congenital pneumonia infection. But in the MCQ, sometimes they ask within 6 hours also. The questions still within 6 hours, and they are referring the condition congenital pneumonia. That's what I didn't mention here. But just as he asked the question, I'm telling congenital pneumonia usually occurs after 6 hours. Okay. Okay. Then this is another common condition to be asked in the MCQ, tracheoesophageal fistula, MCQ SPR. The problem is there are several types of tracheoesophageal fistula, both end blinded and distal end is connected, like kind of. There are several types of tracheoesophageal fistula. So I have given a photo as well. Just go through that. But we have to know in and out about the type C, the first one. This is the common one. This is the most common one, and we have to know about this type very well. Okay, this is called the type C. This is they have mentioned 86%. We have to know this is the most common. Type C is the most common one. And what happened in type C tracheoesophageal fistula is trachea is normal, as always. Trachea is normal. When we take the esophagus, the proximal end is blinded, so we can see. Proximal end, we can see there is no continuation. It is just a blind end. The esophagus comes, the proximal end, and there is a blind end, and the distal end is connected to the trachea. So this is the type C one. Proximal end is blinded, and the distal end is connected to the trachea. That is called the type C. That is the most common type of tracheoesophageal fistula. If you know this type C, that is enough to answer the question. So what happened is, so if we take the type C thing, when we feed the child, whether it's like the first feed will be the breastfeeding, when we put the breast milk come up to this level, it can't go beyond the level because there is a blind end. So what will happen is, for some time it will be stuck there and it will be regurgitated and come into the trachea. So it will go into the trachea and the child will be developing the distress. That usually happen in the tracheoesophageal fistula, any type, but the common type is type C. Okay, got it, ne? So how the patient present is, usually the problem start with the first feed. So we usually feed according to the guideline. We used to feed soon after the birth. We have to give the first feed. Even before measuring the weight and height, we have to give the first feed. So when we're doing the first feed, the problem starts. So that is also soon after the birth. So there will be a feeding. Soon after the feeding, there will be regurgitation. When the breast milk enter into the trachea, there will be a problem. Usually it happens in the tracheoesophageal fistula, but there are some other type of fistula. It may be missed at the time of initial period of life. It may be presented at the later period of life. Kind of this kind of thing. Sometimes there's a small chance it may be missed at the initial period, because when we insert the food, it can go directly into the stomach. But later, when there's some feed once it go into the trachea, the problem starts. So it may take some time in the life. That is a chance. So we have to know that usually it presents soon after the birth, but there are some conditions. Sometime it may present in the later life. So it may be missed up to until that period. So the tracheoesophageal fistula is a congenital deformity. So that is common in diabetic mother. Diabetic mother means type 2 diabetes, not the gestational diabetic, type 2 diabetes or type 1 diabetes. So if the patient mother is a diabetic mother, the chance is high for the tracheoesophageal fistula. So how to manage? So first we have to, once the patient is present, how the patient present? One is a respiratory distress and the other one is a frothing at the mouth. Because it can't go into the esophagus, so it will go into the trachea and all the secretions will be secreted and come out through the mouth. So there will be a frothing at the mouth. So we can suspect these conditions by looking at that, and there will be choking. Choking means so the food enter into the trachea. So that will lead to the choking. So usually it all occurs after the first feed. So when we see the condition in the child, then we have to look how to diagnose. We have to look for the way to diagnose. First, the usual way what we do is we put an NG tube and do X-ray. So when we put an NG tube and do X-ray, what happens is, when we put a NG tube, what happens is, so there will be a esophagus. When we put an NG tube go, because this is a blind end, it will be turning back. So when we do the X-ray, we can see the U-shaped turning of the NG tube. So that what we look at the X-ray. So there will be a U-shaped NG tube turning. So when we see that, we can guess the condition as a tracheoesophageal fistula. So once we diagnose the tracheoesophageal fistula, we have to keep the patient ill by mouth. We should not give anything through the mouth. We have to start the IV fluid, and we have to start the IV fluids, and we have to keep the patient ill by mouth, and we have to refer the patient to the surgical ward for the early correction. Again, the IV antibiotics come in the role because there is a two problem. There's a high risk of pneumonia in this patient due to the aspiration. That's why we are starting the IV antibiotics prophylactically. Empirical antibiotics will be prophylactic antibiotics will be started because whatever that we put in the esophagus, it will be go into the trachea. Secretion also go into the trachea because it can't go into the stomach. So there's a high chance of the child getting infection, pneumonia. So we are starting the prophylactic antibiotics until the proper correction. Okay. That's all regarding the tracheoesophageal fistula. Okay. Then we will move to the next condition. That is diaphragmatic hernia. This is again other common topic to be asked in the MCQ, like meconium aspiration, surfactant lung disease, diaphragmatic hernia, and the tracheoesophageal fistula. Those are the common conditions to be asked in the MCQ and the SBR. Other things can be asked, but not common as these conditions. Diaphragmatic hernia means we know the condition. There will be diaphragm. There will be a defect in the diaphragm. Through the defect, the bowel content will be coming out into the chest. Okay, that is a condition called the diaphragmatic hernia. We know on the right side of our abdomen there is a liver, so it is covering the bigger space. So usually the diaphragmatic hernia occurs on the left side. That is the reason for the diaphragmatic hernia to be occurred commonly in the left side, because right side there is a liver. Liver doesn't allow the bowel content to go into the chest cavity, so it usually occurs on the left side. So diaphragmatic hernia, what is the problem? When there is a diaphragmatic hernia, the bowel content usually go into the chest cavity. So the bowel content go into the chest cavity and prevent the development of the lungs. That is the major problem with the diaphragmatic hernia, not the hernia itself. The herniated content doesn't do anything because it will be go and stay as normal because there is no damage for the herniated sac. The problem for the lung, because for the development of the lung, there should be enough space. But when the bowel content go into the lung space, the lung cannot develop because it doesn't have the enough space to develop. So there will be a lack of development of the lungs. That is the main problem of the diaphragmatic hernia. So we have to treat the diaphragmatic hernia as much as possible earlier. As soon as possible we diagnose the condition, we have to treat it. Otherwise, there will be a lung hypoplasia that can end in the death of the child due to the deficiency of the lung development. That is the most important thing. Not a herniated sac, but the lack of lung development. So how to treat the condition? We have to keep the patient nil by mouth. We should not give anything through the mouth. And immediately we have to intubate and ventilate the child. That is the first thing we have to do. Intubate and ventilate. No any other option like face mask, nasal prongs or CPAP, BiPAP, nothing can be done because whatever we give, it will be go into the lungs and also it will be go into the bowel content, because when we when we don't intubate and ventilate, just give the oxygen through the face mask or something, it will go into the both cavity, like it will go into the lungs and also the bowel content. So the bowel content will be swollen and also it prevent further the development of the lungs. So we should not do anything else other than the intubate and ventilate. We have to keep the patient nil by mouth. Immediately we have to intubate and ventilate when we suspect a case of diaphragmatic hernia. That is the first thing we have to do. Then we have to put the NG tube and do an X-ray to confirm the diagnosis. When we put the NG tube, it will be within the chest cavity. So how to diagnose the condition? But even before diagnosis, with the suspicion, we have to keep the patient nil by mouth, intubate and ventilate. After confirmation of the diagnosis, we have to continue the patient to keeping in the nil by mouth and start the patient IV fluid and immediate surgical referral and correction should be done as soon as possible. That's all regarding the diaphragmatic hernia. If any question, ask me, then we will move to the next one. Okay, this bronchopulmonary dysplasia or chronic lung disease of the prematurity. So this is not a common topic to be asked in the MCQ SPR up to now, but I am not sure because it has been included in the book. So sometimes they may ask the question in the coming period. So that's what I have included this topic. Bronchopulmonary dysplasia itself explain the condition. There's a lack of development of bronchopulmonary system, lungs and the bronchus and the system of the lungs. So that is the condition, because that is this condition occurs due to the damage of the lung. So why the lung damage occurs? The common reason for this is prematurity, and also when we are doing the invasive ventilation, like when we do the intubate and ventilate, there is a huge damage to the lung system. So that can cause damage to the that can prevent the proper development of the lungs. That is commonly occurs in the prematurity. So the risk factors for this condition is a low birth weight, low gestation, again the prematurity. So the problem is it can this condition this condition can prolong for a long period of time. Even if we diagnose the condition and start treating the patient, it will be there for a long period of time. It will take a lot of time to settle and completely cure. Sometimes it may not cure completely as well. There will be a defect through the lifelong. So that's what they are mentioning, long-term respiratory distress and chronic lung disease of prematurity, because this condition can prolong for a long period of time. So when we do the X-ray, we can see the honeycomb appearance and how to manage. What we are going to manage in the patient with the bronchopulmonary dysplasia is we have to reduce the stress to the lungs. We have to reduce the stress as much as possible. So we are giving the diuretics to reduce the amount of the fluid within the lung cavity. So we are giving the diuretics, and to increase, to reduce the inflammation and to increase the surfactant level, we are giving the steroids, and bronchodilator to dilate the bronchial system. And if we need, we will be giving the respiratory support. It can be regarding this condition of the child up to intubation and ventilation. So this other condition, because as the lung is not properly developed, so the immunity is lacking there. So the child is more prone to get the respiratory infection. If it diagnosed early and if we treat the condition properly, the child may achieve the normal lung function later, unless we miss the condition earlier. We have to diagnose early and treat it. So the child has a chance of having a normal lung function in the later life. So we haven't seen a lot of questions on this condition. I'm not sure they will ask or not, but there's a chance because they have included this topic in the new pediatric book, which has been released by our pediatrician. So just have a look on this topic. And this condition, pneumothorax. Pneumothorax means usually doesn't occur spontaneously. It is due to secondary causes, like when we tend to manage the child for other conditions, when we tend to do the intubation and ventilation, usually the pneumothorax occurs as a complication. So when the pneumothorax occurs, we know there will be sudden onset of respiratory distress. Child will be in severe distress. So we have to immediately diagnose and treat the condition. Usually, we treat the pneumothorax as in adults in the clinical suspicious. When we suspect pneumothorax, first we have to go for the needle thoracentesis. After that, we have to put IC tube. First, we have to put the needle and get the air out. Followed by, we have to put the IC tube. That is the actual thing we have to do. But if we have the facility at the ward, we can try the transilluminator. That is kind of torch, and if we flash the torch at the lungs, there will be a brilliant transillumination at the area of pneumothorax. I think I haven't put the picture. You can we can see in the Google. So that will be brilliant transillumination will be seen at the site of the pneumothorax. So, but usually we don't do the transillumination at the ward. In the clinical suspicious, we go for the needle thoracentesis followed by the IC tube. That is the management for the pneumothorax. Okay. Then I think this is the last condition we will be looking. Pulmonary hemorrhage. Pulmonary hemorrhage, it is not a common condition, but it is a severe condition because when it occurs, it has a high morbidity and mortality because treating the pulmonary hemorrhage is very, very difficult. That's what it causes high morbidity and mortality. So we have to prevent pulmonary hemorrhage. So why the pulmonary hemorrhage occurs? The more common in a child who born preterm or low birth weight, because the clotting mechanism and the factors are not developed properly. So they are high risk of developing pulmonary hemorrhage, and also their lung respiratory system also not developed properly. So again, they are having high risk of pulmonary hemorrhage. So it is more common with a child with a low birth weight and preterm. So what we can see is the child will be having respiratory distress and recurrent cough. With a cough, we can see the blood stain secretions coming from mouth and the nose. The tube means if you put the NG tube means EG tube, the blood will be coming out of the EG tube. So that is the condition of pulmonary hemorrhage. We can diagnose the condition clinically, but if you want to confirm, we can do the X-ray. We know we can see the whiteout appearance, because when there is a fluid or blood, it will be shown as a whitish area in the X-ray. So by doing the X-ray, we can diagnose the condition pulmonary hemorrhage. So how to manage? We have to intubate and ventilate, because if it other management option we can't try, because we have to deliver maximum oxygen to the lungs, because there's a amount of blood within the lung system. So we have to intubate and ventilate to deliver the maximum oxygen as much as possible. And to prevent the pain, we have to give the analgesic, and we have to sedate the child until the condition recover. And if there is a coagulopathy, we have to correct the coagulopathy. Usually there will be a coagulopathy, so we have to go for the correction. So we have to do the coagulation profile, and on seeing the result, we have to go for the correction. That is regarding the pulmonary hemorrhage. I think that's all regarding the respiratory distress. We can move on to the question. If anyone have any doubt or question to ask? Anyone? No. Then we will move to the question. So this MCQ regarding surfactant deficient lung disease. So the first one is the ground glass appearance in the chest X-ray is seen. That is true. That's what it's also called the hyaline membrane disease. I think. Yeah, it is also hyaline membrane disease. So, but if we do the chest X-ray, we can see the ground glass appearance. That is true. And the second one is respiratory distress occurs within 4 hours of life. Yes, I told already. It occurs usually soon after the birth. If there's a surfactant deficiency, patient develops respiratory distress once the child is delivered. So respiratory distress occurs within 4 hours. That is true. Antenatal steroids reduce the risk. That is true. That's what in the preterm delivery up to 35 to 36 weeks, we are giving the antenatal IM steroid injection. We have studied in genome. So to promote the production of surfactant substance. So antenatal steroid reduces the risk. That is also true. Congenital pneumonia is a differential diagnosis. We know that because I have told several times. Each and every condition we have studied, there is a confusion with the congenital pneumonia. So each and every time we have to think about the congenital pneumonia as a differential diagnosis. We have to start the IV antibiotics until it is excluded. So congenital pneumonia is a differential diagnosis. That is true. The risk of surfactant deficiency increases with an IUGR baby. This is a trick question. Because IUGR, intrauterine growth restriction, that is, we know this is a stressful condition for the baby. IUGR means there is a lack of development of the child. So that is a stressful condition. Whenever there is a stress, there will be a production of the steroid in our body. That is a normal physiological mechanism. So we know steroid improve the production of surfactant. So whenever there is a stress, that goes for the increment of the increase of steroid, that will prevent surfactant deficiency, lung disease. So the risk of surfactant deficiency actually reduces with the IUGR baby, not increases. So that is false. First four is true, all are true. The last one is a false. I think everyone got the explanation. If anyone have doubt, ask me. Okay. The second question regarding tracheoesophageal fistula, H type is the commonest. We have studied C type is the commonest, so that is false. Present with respiratory distress at birth, not always, but commonly it present with respiratory distress at birth during the first feed. When the mother is giving the first breast milk, there will be a problem. So that is also true. Associated with recurrent pneumonia, I told the feed will be going to the tracheal respiratory system and it will cause the recurrent aspiration pneumonia. That is also true. Boron's immediate surgery. So we have to go for the immediate surgery. Otherwise, we can't do anything with the child. We can't go for the oral feeding. So we have to go for the immediate correction for the surgery. Associated with anal atresia. So that is true. We have heard about this ductal anomaly. That is a condition containing of several anomalies. Ductal means B for vertebral, A for anal, C for cardiac, T for tracheoesophageal, E I can't remember, R for renal, and L for limb.
T is tracheoesophageal.
Okay. Then T for tracheoesophageal. So that is a condition. Ductal anomaly, we mean that is a condition consisting of several condition of anomalies. So altogether we call it the ductal anomaly. So as tracheoesophageal and anal atresia can be associated due to the ductal anomaly. That's what they have expected in this question. So all these questions are true. Okay. Here I have given the explanation for an immediate surgery. I also already told this. H types can be without any problem up to some certain age. So we can postpone the surgery for that condition, but not always 100% for that condition also. There's some chance, but for any other condition, we have to go for the immediate surgery. So for an immediate surgery, we have to take it as a true. Okay. If anyone has any question, ask me. I will let you know if I know the problem. The other one is a newborn baby on treatment with surfactant for surfactant deficient lung disease suddenly deteriorated with a drop of saturation to 75%. A newborn baby with a surfactant lung disease, saturations come to 75%. On examination, they have chest expansion and air entries reduced on right side. So there's a problem on one side. ET tube is in the correct position. What's the most appropriate next step in the management? So they are asking for the management. To find the management, we have to know the condition. What is going on in the child? So if you find out, there's a direct answer. So everyone would have studied about the condition DOPE. So here, DOPE I have mentioned here. This is how we approach a patient having a problem while intubated and ventilated. So when the child is intubated and ventilated, even with the ventilation, if the child is developing respiratory distress or the saturation is going down, we have to think about this condition in a sequential order. First, we have to look whether there's a problem with the ET tube, whether there's a block in the ET tube, whether the ET tube is kinked, or there's a disposition of the ET tube. Because when we put the ET tube, the end of the ET tube should be within the trachea, not in the bronchus. Because when we put the ET tube in the bronchus, one side will be ventilated, other side will not be ventilated, and it will be collapsed. So that is disposition of the ET tube. These are the problem can become with the ET tube. So if everything is normal, then we have to look for other mean obstruction and thinking. Then we have to go for P. That is the condition pneumothorax. So already they have told ET tube is in the correct position. What's the most appropriate next step in the management? So ET tube is in the correct position. So it can be obstructed one, or there can be pneumothorax going on due to the intubation and ventilation. So they haven't given any answer regarding the obstruction or thinking. There's obstruction, we have to get rid of the obstruction, or we have to change the ET tube. So there is no option in the answers for such that like that. Then we have to look for the pneumothorax. And the clue they have given is a chest expansion and air entries reduced on the right side. So there is a problem is towards one side. So that is a condition pneumothorax. So when there's a pneumothorax, what we have to do is, first we have to do the needle thoracentesis. We have to put a needle in the safety triangle, followed by the ICU. So the answer is perform a needle thoracostomy. Nothing else. Surfactant dose we don't need, because the problem is one side, so it can't be a surfactant deficient problem. Increase oxygen delivery won't work, because again the problem is on one side, so nothing will work on pneumothorax. We have to go for the needle thoracostomy. So I think we can move to the next question. The term neonate is noticed for turning blue while feeding and turning pink while crying. What is the most appropriate approach? So I think I haven't given this topic in our what we have taught. So we have to think these kind of questions, because these kind of new questions can be coming. So a term neonate is noticed for turning blue while feeding and turning pink. Turning pink means the child is normal while crying, and the problem occurs only when feeding. So when the child is crying, there is no problem. Feeding, there is a problem. So we have to connect both. So while crying means when the child cry, what happened? The mouth is well open. Mouth and oral cavity is well open. So the problem settles. When feeding, the problem starts. So there is something in the pathway. So, but there is a condition we know. We have studied this condition, that corneal atresia. Corneal atresia means, I think I haven't, sorry, I haven't given the picture. So, corneal atresia means the nasal cavity is, usually there's a continuous cavity, no? But there is a obstruction in at the back of the nasal cavity. Usually it can, the obstruction can be as a septum, or it can be a bone. Whatever, when there's a block, there's a problem. The problem usually occurs when there's a bilateral obstruction. Because when there's a unilateral obstruction, there won't be any problem, because one cavity is more than enough for the ventilation. But if both sides are blocked, then child can't breathe through the nasal cavity. Child should use oral cavity to ventilate. So what happened when we feeding is, when we are doing the feeding, we are obstructing the oral cavity with the food. So child can't breathe. So there will be a development of the hypoxia. Child will turn into blue. Then child will start crying. When the child cry, the mouth cavity widely open. So there is enough ventilation for the child. So the child turn back into the pink. So likewise, we have to think and guess the condition. So this is the condition, corneal atresia, bilateral corneal atresia, not a unilateral. So how to diagnose the condition? Usually, if we suspect the condition, initially we can do that tongue depressor, metal tongue depressor. We can put it near the nasal cavity and see whether it is getting humidity. That is a normal way of looking at. The proper way is to put an NG tube and take an X-ray. When we put an NG tube and take the X-ray, the NG tube won't go in. Usually no need of a chest X-ray as well, just an NG tube. If you put the NG tube, it won't go in. It will be blocked. So put an NG tube is the appropriate way. Why we use chest X-ray actually in the bilateral corneal atresia is to differentiate whether the obstructed part is a bone or septum. If you do the chest X-ray, we can differentiate whether it's a septum, whether it's a bone. To differentiate that, we can later do the chest X-ray, but the best way to diagnose the condition is an NG tube. Then we have to go for the surgery. Okay, that is the condition called the bilateral corneal atresia. We will move to the next question. A baby born at 32 weeks was ventilated due to surfactant deficient lung disease. He suddenly deteriorated and his oxygen demand increases during the last 15 minutes. On examination, the chest expansion and air entry were reduced on the right side. What is the next step of management? Same kind of question. No need to repeat and look at the question, because the answer is needle thoracentesis. This is the repeated question. So just see that they are repeatedly asking. Just remember the door when we are try to answer this kind of question. Okay. Then this question: a baby was diagnosed to have diaphragmatic hernia antenatally. At birth, child had respiratory distress and was cynosed. What is the first step in the immediate management? So they are asking, what is the first step? So diaphragmatic hernia, we can do a lot of things. The first step we have to do is we have to keep the patient ill by mouth and intubate and ventilate. Nothing else. If you take the answer, yes, we have to do the NG tube at some point, because whatever the secretion secreted, we have to take it out. So we have to put the NG tube. That is true. Nasal CPAP oxygen or nasal prong oxygen, that is absolutely wrong. Because other than the intubate and ventilate, we can't do anything. I explained the reason. We have to do only the intubation and ventilation. Once we suspect the condition, diaphragmatic hernia. So later also we have to go for the IV fluids, and sometimes we need chest X-ray to diagnose, properly diagnose the condition. But they have asked, what is the first step? First step is always ET tube. If you miss the ET tube ventilation for some time, there will be a lung hypoplasia. So we have to prevent that. So ET tube insertion and ventilation is the first one. Okay. So I have given the explanation as well. Okay. This is other condition, the same regarding the congenital diaphragmatic hernia. So I think this is true false. Commonly occurs in the left side. That is true. I explained, because right side there's a liver, so rare to occur on the right side. Commonly on the left side. Present with respiratory distress at birth. That is also true. Soon after the birth there will be a distress. Resuscitated with mask and back ventilation. That is false. Repeatedly I'm telling, only way to ventilate, oxygenate the patient is intubation and ventilation. Nothing else. That is false. Needs NG decompression. That is true. Whatever the secretion, we have to take it out. Needs immediate surgical correction. That is also true. As soon as possible, we have to do it. So that is okay. I think that's the last one. 1 hour old baby is respiratory distress. On auscultation, heart sounds were heard on right side. Abdomen is scaphoid. Saturation is 87. What is the management? So again, they are meaning a condition of a diaphragmatic hernia. When there's a diaphragmatic hernia, the hernial sac, the content is herniated into the lung cavity. So the abdomen will be empty. That's why there will be an observation of the scaphoid shaped abdomen. Scaphoid means, we know that this kind of abdomen will be like this. Scaphoid abdomen. So heart sounds were heard on the right side, because I already told the herniation on the left side is common. So when the content is herniated on the left side, the heart will be pushed to the right side. So the heart sounds are heard on the right side. So this is absolute condition of a diaphragmatic hernia. So the first step we have to do is intubation and ventilation, nothing else. Okay. So diaphragmatic hernia, the answer is correct. So this is the last question, I think. 3 kilogram term baby born by spontaneous normal vaginal delivery was noted to have respiratory rate of 80. So respiratory distress, because normal range is less than 60. So 80 is higher than the normal. After 3 hours, he also had chest indrawing and grunting. So they are giving more clue for the respiratory distress. Membranes were ruptured 24 hours before delivery. So membrane ruptures more than 18 hours. So that is a high risk for congenital sepsis or congenital pneumonia. We know that. Or chorioamnionitis, that is a risk factor. Mother was healthy. She attended antenatal care regularly and had uncomplicated pregnancy with normal ultrasound scan. Everything other than normal. They are meaning that. Probable diagnosis. We will be looking at each and every one. Diaphragmatic hernia. So to think it as a diaphragmatic hernia, the problem is soon after birth there will be a respiratory distress. It won't be there won't be delay of 3 hours actually. So, and also there is no any other evidence to suspect diaphragmatic hernia. we have seen a lot of questions. They are giving the evidence like scaphoid abdomen, heart sound on the right side, kind of evidence they usually gives. So we can exclude diaphragmatic hernia without any doubt because there is no evidence to suspect diaphragmatic hernia. And so then we will leave the B and C, look at D. Surfactant deficient lung disease we can exclude because there is no risk factors for the surfactant deficient lung disease because this is a term baby. The surfactant deficient lung disease very rare in the term baby. It can occur but very rare. So we can exclude that as well. Transient tachypnea of the newborn, that is usually occurs in the baby with a cesarean section. So that is also rare. B and C both can be there. Congenital pneumonia and meconium aspiration syndrome. The problem is if we take the meconium aspiration syndrome, usually it occurs soon after the birth. Congenital pneumonia, I already told, it usually occurs after 6 hours. It means late onset. That what they are meaning. Congenital pneumonia is a late onset, not immediately after. So this is fitting. Congenital pneumonia fit for everything. It causes respiratory distress, respiratory rate 80 after 3 hours, and also they are giving membrane burr rupture 24 hours before delivery. And also they are telling there is a high risk of chorioamnionitis. So high risk of congenital pneumonia. So then we can go for the answer. Congenital pneumonia. Okay. I think that's all we have to cover the topic. So we will move on quickly. So anyone have any doubt? If someone have any doubt, just ask me. We will move to the next one. Can we try because I had 2 separate slides, so I will share it as a PDF file. No, I will share it. Sorry, because you have just asked, so I didn't think about sharing. So I have shared my slides. I have at the moment. I will share the total document as a PDF. Okay. So if someone have any doubt at the respiratory distress, can ask. Now we will start on the new other topic. This is neonatal resuscitation. So okay. Sometime regarding the last topic, the previous topic, sometime you may be asked question on short essays or part of the large SEQ like congenital pneumonia, how to manage a condition. Those kind of question can be asked as a part of a long question, not a full SEQ. That is so rare. So just know the basic, the overall idea, then you can even write the SEQ answer. No need of worry because they will be in the SEQ. Even if they want to ask the SEQ, they will be asking the common topics, not the rare one. Commonly the congenital pneumonia, meconium aspiration kind of topics only they will be asking. Okay. Then we will start neonatal resuscitation. So at birth, these are the no need to remember these stuff. Just I'm giving the broad overall idea how to approach a child at birth. So what problem the child is having at the birth is the body surface area is high, so prone to hypothermia. Hypothermia means loss of heat is high, so we have to prevent that. And lungs is not expanded properly, so they are also more prone to get the respiratory distress. And even if you do the oxygen saturation soon after birth, some child may be having the less oxygen saturation. To reach the 90% oxygen saturation, sometimes it may take 10 minutes. So that's what they are meaning. It will take some child, not everyone. Most of the normal child will be having the 100% at the time of the birth. But for some child, it may take 10 minutes. That is normal. That's what they are meaning. Then, no, this is not a preparation before surgery. Preparation before delivery. So I will change it and send it. Preparation before delivery. So oral idea. Before the delivery, we have to make sure that we are preventing the infection as much as possible. So hand washing, double paired gloves, sterile kit for cord clamping. Cord clamping means now we are using the plastic cord clamp, nothing else. Nothing else we can use according to our guideline. Only that we know that pink, blue color plastic cord clamp is there. That is the only thing we can use. Nothing else can be used to clamp the cord for the child. Okay. Temperature control, we have studied this. We have to switch off the AC, fans, and we have to close the windows, and we have to turn off the warmers. Especially if you want to resuscitate the baby, if you're expecting a baby with a bad condition, we have to get ready with all these things. We should have turn on the warmers prior to the delivery, and we have to be prepared. And we have to keep the warm towels and help mother to wear simple clothes because it will ease the mother for the care of the baby. Okay. And ready for the resuscitation. So we should not wait until the child is delivered. So we have seen a lot of resuscitation at the neonatal ward. So once before the delivery, we have to ready with each and everything. Whatever we have studied up to now, we have to be ready. We have to check the oxygen cylinder or oxygen supply, whether it's coming. We have to make sure face mask and gloves and warm towel all are okay. And we have to make sure the warmer is on and the heat is coming. And suction apparatus and all the equipment should be ready to work. So that we have to make sure. And what kind of care we have to give during the delivery. And we know that nowadays it is commonly done. We have to deliver the baby to the abdomen of the mother. There are reasons for that. To promote the colonization of the common cell organism, to prevent the culture of the pathogenic organism. And also when we deliver the baby on the abdomen, the heat will be directly delivered to the child. So we can prevent the heat loss. And also it will be improve the attachment between the child and the mother. So the breastfeeding will be improved. And once the baby is delivered, the time of the delivery should be noted down. And we have to dry the child with 2 towels. First, we have to immediately dry the fluid of the child. And then we have to, with the second towel, we have to wrap the child. That usually done. And delayed cord clamping, we know that. For that cord clamping, we have to use the plastic kit. These are the things. These are the things can be asked in MCQ. Just have an idea. So this 5 centimeters away of the abdomen is a standard way. So from the abdomen, we have to clamp the cord from the 5 centimeters. Like if the abdomen is here, there will be we have to cut this at 5 centimeters, and here we have to put the plastic kit. So these are the things can be asked in the MCQ. Just make it sure that you have an idea on that. So assess the condition of the baby. We know we can do the ABGA scoring at 0, 5, 10 minutes. But if there's a need of resuscitation, this is the thing we use. CTBG. CTBH mean C mean color, T mean tone, B mean breathing, H mean heart rate. When we need to do the resuscitation, we are going for the CTBH. Otherwise, the common assessment also can be done with the ABGA score. So we will see the ABGA score when we are doing the MCQ. So just also remember the CTBG. Okay. Okay. So these are the things you know. So just have. So this is the other important things we have to know. Before transferring the delivered child to the postnatal ward, we have to make sure the first breastfeeding has been done. Because second breastfeeding is usually done at 4 hours, I think. So first breastfeed should have been done before transferring the patient to the postnatal ward. After the breastfeeding, we have to measure the weight and the length and the OFC, and it should be properly documented. Vitamin K prophylaxis is a must. It is usually done soon after the birth. At least it should be done before 24 hours. And vital monitoring should be done 30 minutes for 2 hours. Not a compulsory one, but it should be done ideally. And if there is a problem with the child, pediatric house officer or doctor from a medical officer from the neonatal unit should be informed. Like heart rate more than 200, less than 100, just go through these parameters. And temperature measurement should be done and it should be documented. These are the things can be asked in the MCQ. The vitamin K prophylaxis, when it is done. So those kind of statement can be asked in MCQs. Just keep in mind. And these are the things should not be done while delivering the baby. Just go through the notes. Nothing to explain more. I have told everything. Okay. So these are the condition we consider as a poor condition for the baby at the time of delivery. Like the color. Usually the child should be in a pink color. If it's blue or pale, that is bad. Usually the child should be moving all the limbs properly. If there's no movements or lack of tones, that is a poor condition. Breathing, the heart rate, the respiratory rate should be between 20 to 60 and there's a proper breathing. There should be no grunting or symptoms of respiratory distress. So if there's no breathing, irregular breathing, there is also a problem. Heart rate should be more than 100. If it's less than 100, that is again a problem. So that is, keep it, remember this one. So then if the baby doesn't cry after birth, so we are delivering a baby, the baby is not crying. Then what to expect, what to do? That is the neonatal resuscitation that we are going to study. So what are the problems when the baby doesn't cry? If the child doesn't cry, the fluid doesn't go out. Because when the child cries for the first moment, the fluid within the lung system, the respiratory system will move into the circulation. So if the child doesn't cry, fluid doesn't go. So it will lead to the lung collapse. So there will be a lack of gas exchange. So hypoxia will go. Hypoxia can cause hypotonia because muscle need oxygen for the proper movement. So there will be hypotonia of the muscle, especially the tongue muscle. So when there's hypotonia of the tongue muscle, tongue will be falling back. That will further cause obstruction of the airway. So this is a circulatory kind of thing. So we have to know that what happens if the child doesn't cry. Why we are giving the more important for the first cry of the baby. These are the reason for that. Okay. So then we will move to the proper neonatal resuscitation. How we are going to do the resuscitation when the child condition is poor. Means the child is not crying. First one, if the child doesn't cry and there is no respiratory movement, the child is like a doll, there's no movement, then what are we first going to do? First, we have to make sure that the airway is open. That is the first thing we have to do. To open the airway, we have to keep the child in the neutral position. Nothing else. I have put the picture. Sorry, I did. Neutral position mean usually in adult we know when we are going to do the ventilation, we usually extend the neck. But in the child, we should not do because the head body ratio is not as adults. The neutral position means everything should be in the same line, like this. Sorry for my drawing. Like this. There should be no flexion or extension at the neck. The total body surface should be touching the surface. Okay, that is called the neutral position. After putting the neutral position, we have to look whether there is a chest movements, whether the child is breathing. If the child is breathing, no problem. We will transfer the child to the neonatal unit or the baby unit, and we will do the initial management there. But no need to worry because the child is breathing. But even after the neutral position, if there is no breathing, then we have to go for inflation breath. Inflation breath means we have to put the ambu bag and we have to put continuous 5 presses. We have to make sure that we are using 500 milliliter ambu bag. Nothing else can be used. Only bag we can use is 500 milliliters. That is a standard one. Inflation rate, there is a technique to give. Everyone would have taught by madam that 1, 2, 3 push, 2, 2, 2, 2, 3 push, 3, 2, 3 push, 4, 2, 3 kind of. We have to count that, and with the rhythm, when we telling that push, we have to give the push. So 1, 2, 3 push, 2, 2, 3 push. That is a practical thing. They won't be asking the question. Just I'm telling. So kind of 5 inflation breath we have to give. And there is a way of holding the mask that is called the C and E method. We have to, with the thumb and the index finger, we have to hold the C and hold the mask on the face. And with the E, we have to hold the mandible bone, as shown in the picture. So that is the way of giving the inflation breath. After giving the inflation breath, we have to, while giving inflation breath, we have to look the chest, whether the chest is moving. Because then only we can know that whatever we are giving the air is going into the lungs. If there is no movement, even with the inflation breath, that with the push, if there is no movement, so whatever we are giving not going into the lungs. So we have to think that there is some problem. So if the lungs is not moving even with the inflation breath, again we have to go to the first stage. We have to make sure the child is in the neutral position. Then we have to repeat the inflation breath again for 5 times. So we have to go repeatedly until there is there's a respiratory movement. Mean the lungs is expanded. There's a chest movement. So once the chest is expanded, we know that whatever we are giving, the air given is going into the lungs. Then we have to look for the heart rate, whether the heart rate is more than 60 or less than 60. So for that, the madam told a way of listening the heart sound, that tapping sound, whether that is the speed of the sound we have to know. And the ideal thing is whether the heart rate is more than 60 or less than 60. If the heart rate is more than 60, something regarding the heart is properly pulsating. So the problem is with the respiratory system. So we will be going with a ventilation breath. 15 ventilation breath. 15 ventilation breath mean without that we don't need to count. Continuously we are giving the 15 ventilation breath for the child. Unlike in the inflation breath, we don't need to count and we not going for the rhythm. Just we are putting 15 inflation breath. So that is called the ventilation breath. We have to go for the 15. But if the heart rate is less than 60, then there's a problem with the breathing and the circulation. There's a problem with the lungs and the heart. Then we have to manage both. So how we are going to start it? Anyway, even if the heart rate is less than 60, initially we will start with the ventilation breath. We will be giving 15 ventilation breath. Then we will look for the response, whether the child is responding. If the child is responded, okay. If everything is normal, we will transfer the patient to the neonatal ICU. We will manage the patient and later we can discharge. But even if the ventilation breath, the child is not responding properly, then we have to start the cardiopulmonary resuscitation, CPR for the child. The ratio what we start for the child is 1:3 ratio. For 3 chest should be given. So that CPR is started after giving 15 ventilation breath only. Anyway, we will be giving 15 ventilation breath initially, then only we will be starting the chest compression. And like that 1:3 ratio kind of thing we will be doing for 15 cycles. 1:3 kind of thing we will be continuing for 15 cycles. After the 15 cycle, again we will be assess the child. If the child is improved or not. If the child is improved, then again we have to start the resuscitation. We have to transfer the patient to the neonatal ICU. Then we have to manage there. Even after the 15th cycle, if the child is not improved, then we have to go for the next management. That is, we have to put the umbilical venous catheter. We have to put a catheter in the umbilical vein and we have to administer 1:10,000 ratio of 0.2 milliliter per kg adrenaline. After administration, then we have to again continue the chest compression. Like we will go the 15 cycle, then assess, then administration of the adrenaline, 15 cycle, like kind of thing we will be repeating until the child is getting well. Like that, we can go up to only 20 minutes. Because if even after 20 minutes, if there is no response, almost child is dead. So we have to discuss with the pediatrician and we can stop the resuscitation and we can finish it off everything. That is a decision that is taken after 20 minutes. Until that, we have to go for the repeated cycles. This is up to this. I think that is all for the neonatal resuscitation. I think everyone got it. So we can move to the question. So here, baby born by normal vaginal delivery was pale and floppy at birth. No respiratory effort, means child is not responding, no respiration. Heart rate is very, very poor. 5 inflation breath given with adequate expansion. So they have anyway put the patient in the neutral position because they haven't mentioned that. So we know that when they are going to do the inflation breath, child should be in the neutral position. So child has been put on the neutral position. They have given the inflation breath. With the inflation breath, they are telling that there's an adequate chest expansion. So inflation breath is succeed. And after that, they are reassessing the child. There was only occasional gasping. Means child is finding very difficult to respirate. There's a problem with respiration still. And the heart rate is very, very poor, 40. So what is the most appropriate next is in management? So we have studied. So if there's a condition like that, then we have to go for the 15 ventilation breath, nothing else. After 15 ventilation breath also, if the condition stays same as given above, then we will be starting the chest compression at 1:3 ratio. Okay. So IV adrenaline infusion, that is the last option. We will going for the option later. Ventilation with back and mask, face mask, nothing. We call that is ventilation breath. Continuously we are giving the 15 ventilation breath. Give 5 inflation breath. No need for that because already they have given the inflation breath and there's adequate chest expansion. So no need to go for that. Intubate and ventilate, no need at this moment. We have to go for the 15 ventilation breath. That is the answer for that. Okay. I have missed one question. They have asked, Machan, can you explain what 10 minutes? Usually, when the child is born, there should be a lot of physiological changes should occur to adapt to our new environment. So, for the child to reach the proper oxygen saturation, mean more than 94, it will take some time. So, what they are telling is, up to 10 minutes, it's okay. To reach more than 94% or 90%, up to 10 minutes, it's okay. That's what they are telling. So after the delivery, we are checking the saturation at 5 minutes. Still the saturation is 88. No need to worry that much. So we can wait until 10 minutes if other parameters are normal. Only the problem with the saturation. But the child is not breathing at all, heart rate is very low, then we can't rely on the saturation. I am telling, if the problem is only with the saturation, we can wait for 10 minutes for the saturation to pick up above 90%. That's the thing. That's a studied one. That's what they are telling. I think I have answered the question. Janaka, Harida. Okay. So, you are attending a baby delivered at 38 weeks by cesarean section due to fetal distress. Leica is not meconium stain. Baby is floppy and having poor respiratory effort and bradycardia. What is the next step in management? So baby is floppy and having poor respiratory effort and bradycardia. So having poor respiratory effort means the child is anyway having the chest movements. Child is not like child is not like a dead one. It has a respiratory movement. There's a still movements in the child. So what we have to do is, next step, we can directly go for the ventilation breath. If the child doesn't have any breathing, so his child looks like a blank one, then we will go for the inflation breath. Then we will go for the ventilation breath. But here, anyway, child is having some kind of respiratory effort. The child is trying to grasp the oxygen. So, no need to go for the inflation breath. Directly we can go for the ventilation breath. So that's it. The answer is 15 ventilation breath. So other answer won't be there. Only there will be some confusion with the inflation and the ventilation breath. So that's what I have taken, the ventilation breath. If anyone have any doubt, just ask me. Don't go with any confusion or doubt. So that's all I could find as a MCQ. Just when you're doing, just look at whether there are any other MCQs. So, okay. SEQ. This is a common topic. And what is the difference between inflation and ventilation breath? Inflation breath means that is the first thing we are giving the breath. We are giving that in a kind of a rhythm. Like I already told me, that's a way of giving that. 1, 2, 3. Actually, we have to count and give. We have to count 1, 2, 3 plus 2, 2, 3 plus 3, 2, 3 plus. Kind of we have to count in a rhythm. We are giving the push. That is not to deliver the oxygen. That is to push whatever the fluid within the lung cavity outside. So when we see a child without any respiratory movements, nothing there, then we have to start with the inflation breath. We have to put the patient in the neutral position and we have to start the patient in the inflation breath. That is to push the fluid out and to see whether whatever we are giving going into the lungs. That is a inflation breath. Ventilation breath means ventilation. The name itself implies the meaning. Ventilation. We are giving the oxygen with a ventilation breath. Inflation breath is to make sure the airway is patent. Ventilation breath is to deliver the oxygen. Likewise, we can take it. That is a difference. So both are not equal. So this is, I will explain one question. The second question is same as this one. Just go and have a look at it, because I think the time is already 7:30, so we can finish on time. You are called to attend delivery of a baby of a diabetic mother. So diabetic mother delivering a baby at the term 39 weeks. We have emergency C-section. So this is an emergency C-section. Baby did not cry at birth and was found to be pale, floppy, lethargic, and had no respiration. Baby had a slow heart rate on auscultation. So they are giving all the parameters, but we had to know to guess our management. So initially they asked me state the ABGA score of this baby giving reason. So just look at this. This is 30 marks question. So they are giving 30 marks for that. So we have to properly answer that. That is other one. We sometimes we may know how to calculate the ABGA score, but we won't be showing that in the answer. So we won't be getting the full marks. So if you won't show in the answer, we have to write it properly in this method. Just at least you have to write this chart. We have to write it and we have to calculate the score, and total score 1 is out of 10. So ABGA score is 1 out of 10. For that, you have to know this chart. I think I have cut that part. This is the ABGA. A mean appearance, P mean pulse, G mean dryness, and respiratory or something. There's a ABGA score. Just Google it. This is the chart for that. Google it and remember the chart and remember the score. That is easy to remember. Just have an idea. Sometimes they may ask, because this is a past paper question. Okay. So the problem is we may know the answer, but sometimes we may directly answer 1 out of 10. Sometimes you may get only 5 marks out of 30. So just write it properly, at least this one. If you have time, just write all this, all the chart and calculate the score. Then you will definitely you will get the full marks. Okay. Then the second question, the same baby weight 4.5 kilogram. So because that is a diabetic mother, so that is the reason for the 4.5 kilogram baby, and was found to have the respiratory rate of 80. So 80 means high tachypnea with intercostal recession and grunting. So what they are implying is the child is having the respiratory distress, nothing else. Pulse oximeter was 85%. So saturation is less. Low. Describe how would you manage. So they haven't mentioned any specific condition with that. So the problem is a diabetic mother, large baby. So we can guess the child may be having surfactant lung disease, but we are not sure about anything. So how would you manage this baby? The initial management they are asking. So and they are giving the 50 marks. So we have to approach this question broadly. Just don't think it can be surfactant lung disease and write the answer for that. Just approach the patient broadly. If you write the answer in a broad way, you will definitely get between 40 to 50 marks. Just don't go behind a certain topic. So this is a broad idea I have given. So we can approach the child with ABC. So we have to make sure the airway is patent because there's a problem with the airway. And also, whenever there's a respiratory distress, we have to give the oxygen supplementation at the beginning. Unless that is the case of diaphragmatic hernia. Diaphragmatic hernia, we can go for the oxygen supplementation. Here, there is no evidence of diaphragmatic hernia. So we have to give the oxygen supplementation. And we have to get the IV access. Because that is I have approached this child according to the ABC, IV access, and we have to get the blood. In the blood, we have to get the blood for the certain investigation. This is a diabetic mother, so there is high risk for the hypoglycemia. So blood sugar we have to get, and along with that we usually do serum electrolyte, CRP, and also we have to get the blood for the blood culture and ABG because it can be sepsis. And we have to keep the patient nil by mouth. So I have missed that name. Yeah, we have to keep the patient nil by mouth. So until restarting the feeding, we have to start the patient on the IV fluids. And also we have to do the continuous cardiac monitoring. Also we can mention within the continuous cardiac monitoring, we are monitoring heart rate, pulse rate, oxygen saturation, respiratory rate. So this is an emergency condition. We have to inform the seniors, and also we have to inform the ICU. So in case of need of ICU, we have to be ready. So inform the seniors and ICU. And also we are thinking of a condition of infection or surfactant lung disease. So we have to give an idea, telling them that we are thinking about this condition as well. If we show them, that is enough. So we have to arrange for the urgent chest X-ray to look for the features of the surfactant lung disease and the congenital pneumonia. We can even mention that. And at the same time, we have to start the antibiotic prophylaxis because I have already told we can't exclude pneumonia. That's a problem. So prophylactic antibiotics with penicillin and gentamicin should be started. And also at the same time, we know this is a large baby. There's high risk of hypothermia, hypoglycemia. So we have to measure the temperature and we have to take the measures to prevent hypothermia and hypoglycemia. So if you remember at the time of your answering, just mention some answers for that, how to prevent hypothermia. Put the patient on the warmer, turn off AC, fan, close the windows, kind of answer you can give. Then they will know that we know that how to prevent hypothermia. And as soon as possible, we have to start proper feeding. Once the initial management is done, we have to start the breastfeeding, if it's possible. And the far more important thing, don't miss this when we managing the child, counsel the parents. At the same time, parallelly, we have to do the proper counseling for the parent. Always mention that counseling of the parents. Don't miss that. That is a more important part. So if you mention that, mostly you will be getting more than 40 marks, sometimes even 50, I'm not sure. For more than 40, you make it. The next question, then after 2 hours, you look at jitteriness. Jitteriness means fixed kind of thing, shaky movements. So they are looking for the causes. So the child we know is a diabetic mother. Common cause for the diabetic child, the child for the diabetic mother is hypoglycemia. So that is one of the common cause. And also, we are doing the resuscitation, and also the initial breastfeeding is postponed. So there will be electrolyte imbalance, and also we are exposing the child to the environment, hypothermia. So even it can be infection. So you can think of a lot of cause. But as we are doing the resuscitation, and as the mother is a diabetic mother, I have thought as initial causes: hypoglycemia, hypothermia, electrolyte imbalance. These are not only the answers. You may think other answers that regarding your case scenario. Here, as a diabetic mother, you have to, I think you have to mention hypoglycemia. That is a common cause. So if you write all, you will be getting full marks. And I have given this one SEQ, but I don't have the time because I think you may have other batch. So we will finish it now. So if anyone have a doubt, ask me. Otherwise, we can wind it off now. If anyone have any doubt, I don't know whether I have moved somewhat fast because I have lost some time at the beginning. Sorry, I think almost okay. So if anyone, please share both. Yeah, I will share the full document as a PDF file. Don't worry. I'm so sorry because I don't have at the moment. That's why I couldn't share. So if anyone have any doubt, just ask me even in the private message. No problem. So study well. I think you have little period. So passing the exam is so easy. Just concentrate and study in a focused manner. Just don't study each and everything. Just study in a focused manner, and you can pass easily. Go through the MCQ and do it. If anyone have any doubt, not in even in these topics, other doubts also, if you want, you can ask me. Okay, no problem. So have a good time. Good night. Bye.
Thank you.
Thank you.
Okay, bye.